Our quasi-final panel this afternoon is about the health AI deployment landscape. So I think rules of the road for deploying health AI are fluid and unsettled. So we're going to be taking a little time to explore the societal context in which health AI innovation, investment, and policy are playing out in the real world. As we've heard all day long from an inspiring group of speakers, things are moving fast. So questions for the panelists are around how are we and how should we be thinking about how to balance facilitating innovation, enhancing equity, and also establishing guardrails and safety. So we heard a little bit about from the building trust perspective. Now we're going to look at it from like deployment and policy perspective. Is there a tension between these, or if it's done right, is there not a tension between these? And we're going to be hearing from three real leaders and thought leaders in this space. Dr. Palav Barbaria, who's Chief Quality and Medical Director and Deputy Director of Quality and Population Health Management at the California Department of Healthcare Services, leading, among other things, state efforts to use data integration and data-driven insights, including ML-based approaches to strengthen the healthcare safety net. Going to be hearing from Cora, who's Chief Health Data Officer for the University of California Health and Executive Director of the Center for Data-Driven Insights and Innovations. I'm really a leader at the intersection of technology, governance, and healthcare with specialties in data management, trustworthy AI, and data privacy. And then finally from JP Pollak, who you heard a little bit earlier today, co-founder of the Commons Project, and among many other titles, who builds tools and conducts research to help individuals collect and make use of their own health data, and is one of the creators of Common Health. So without any further ado, I will take it away. Each of our speakers has a lightning talk teed up, and then we'll roll right into questions.
Great. Hey, everyone. Thanks so much for having me here. Raise your hand just so I get a sense. How many of you in your research or work are looking at Medicaid or Medi-Cal in any way, shape, or form? Okay, so a few, but certainly not the majority, and I think that is a huge part of why I am here today. So my role at Medi-Cal is me and my team are responsible essentially for making sure that the 14 million Californians enrolled in our state Medicaid program, also known as Medi-Cal, have high-quality, equitable health care with the outcomes that any of us would want for ourselves or our loved ones. In California, if you're not familiar, our Medicaid program is largely managed care-based. So about 94% of those 14 million people are enrolled in one of our 22 managed care plans, and there's a small percentage in fee-for-service. But really, it is through our managed care delivery system that we affect the most change. So as a part of CalAIM, which is the multi-year Medicaid transformation that the state has undertaken, we launched sort of Medicaid's first ever comprehensive population health management program in our state in 2024. And the goal of this was really, how can we use the dollars that are all publicly funded taxpayer dollars, both state and federal, to really achieve better outcomes for our members? We know that we have a disproportionate share of really complicated individuals who are often cycling in and out of emergency rooms, skilled nursing facilities, EDs, that take up a huge part of that budget. And then on the flip side, we also know that when you look at all of our upstream preventative scores, whether it is for children's screenings or cancer screening or just managing chronic disease before it gets too severe, that we aren't doing a great job as a state. And so when we think about just the landscape of California, 1 in 3 Californians is on Medi-Cal, right? So when we think about how is AI being rolled out in healthcare landscapes, if we're not talking about Medi-Cal, if we're not talking about the safety net delivery system, we are literally leaving out a third of our state, and the impact is going to be significant and likely worsen disparities that we already know exist between Medi-Cal and commercially insured members. So to really address this, hand in hand with our Pop Health program, which is really a policy program, so it is health policy and contract requirements that our managed care plans have to implement, we knew we really needed to start to also tackle the technological divide that exists within our safety net in California. And so we've launched something called Medi-Cal Connect, which is a statewide platform that Maya and some of her colleagues, as well as our vendor, Arcadia Analytics and Gainwell, have been helping us build. And the goal of that platform was to really level the playing field so that our managed care plans, some of our small counties that run county behavioral health, can really have access to the types of large data and data-driven insights and predictive modeling that is very commonly used outside of the safety net today. We'll get into this more in the panel, but one of the innovative things I think we've done is we at DHCS sit on a ton of data, right? So for those 14 million people, every claim, every encounter, every healthcare touch, we have an entire data warehouse filled with that data. We also have been undertaking a lot of really robust data sharing agreements with other state partners. And so when you think about comprehensive whole person care and really addressing the upstream social drivers of health like food insecurity or housing, it's hard to get at those insights with just healthcare data alone. So we now have data sharing agreements where we have SNAP data called CalFresh in our state, WIC data. We have all of the housing data that flows up to HUD that we are getting at the state level. We have numerous public health data sources, including our immunization and other disease registries. And we are now pulling together all of that data, including social services, child welfare, so that at least for the 14 million people on Medi-Cal, we have a comprehensive look about what social services are you using, what housing services are you using, are you on food stamps, what other benefits do you have, in addition to all of the healthcare data, so that we can really predict what our members' needs are and hopefully, outreach them and engage them in services before those needs becoming detrimental to their health. And all of this is done sort of with our data warehouse infrastructure and then this new platform, Medi-Cal Connect. So to just give you a scale, our new platform, we have longitudinal medical records now that span behavioral health, physical health, and social services for all 14 million individuals. We have over 250 quality measures spanning value-based care, again, behavioral, physical health, and then we have access now for, our 22 managed care plans and 58 county behavioral health plans who can use this in managing their populations. And then the last part that I'll tee up for our conversation is, as a part of this, we knew that a lot of the existing risk score predictors in Medicaid, they're really archaic. They use maybe a handful of ICD-10 diagnoses. If you're really lucky, you get some pharmacy data in there, but they aren't great. They leave out huge populations. They don't work really well on kids, and they don't really address any of the social drivers of health. We also know that the commercially available predictive algorithms often are a black box, and so they can perpetuate racial and other ethnic disparities. You often don't know what you're predicting, and they're often designed to be about cost containment as opposed to actually achieving the population health outcomes that we are most interested in. And so we have actually built our own open source machine learning based algorithm that uses all of that data I was just talking about to really predict who are in these various tiers, and really looking at not just who's going to have high risk of behavioral health or physical health adverse events and utilization, but also underutilization, which in the Medicaid space is a huge problem that we know there's lots of people who have insurance coverage and aren't getting any preventative care or basic health care whatsoever, and it's a much larger issue than in commercial populations. So this just covers some of the inputs and outputs of those three different domains that we are predicting, and then we'll get into more in our discussion.
Thank you. That was awesome. I have many questions for you as well. Okay, so I called my talk "Move Fast, Govern Well," because it's clear that the technology landscape is moving very quickly, but in these boxes, and I apologize that they did not show up here, but there's also the regulatory landscape and the socio-technical landscape, and those are also both evolving, perhaps not as quickly, perhaps not as evenly, but they are also parts of how important it is to have health AI be deployed appropriately and successfully. Okay, so what is happening in the regulatory landscape right now? I'll say that we're seeing kind of an interesting push-pull. On the federal side, we're really seeing a push towards deregulation. Here are 3 data points, the first coming from the White House AI Action Plan in the summer of 2025, really setting forth a roadmap for federal policy to accelerate AI innovation and remove onerous regulation. And this is across all areas, including healthcare. Another data point comes from the end of 2025, when the Office of the National Coordinator for Health IT proposed to eliminate many model card requirements and also certification requirements for EHR systems as they are going through that process. That is a proposed rule, but that is definitely the direction that that agency is going. And then finally, from FDA too, a deregulatory push in their clinical decision support software guidance, really easing regulation for certain digital health products. So in California and in the States, we're seeing a lot of activity, however. Irene was absolutely right that there are always a host of bills being considered, and this audience should really, I think, become involved and read as to what they are and have your voice really be part of the conversation. But here are two recent bills that were passed. The first is SB 53, which relates to public transparency reports and also whistleblower protections for large frontier AI developers. And the second is AB 3030, which applies to generative AI being used in patient-facing communications and the need for transparency and disclosure when it comes to those kinds of communications. But I want to point out something else interesting that's happening in the regulatory sphere, and that is this idea of regulatory sandboxes. And we're seeing this both on the state side and also on the federal side. So what is a regulatory sandbox? It is, I would say, defined in different ways, but largely a safe, protected environment for new AI models to be tested and monitored with an understanding that some of the existing regulatory requirements may need to be eased so long as it is within this protected environment. So for example, and some people here may have seen this in the news, but Utah rolled out with Doctronic a partnership for AI prescription medication renewal. So only renewal and limited to certain chronic conditions, and built in other protections such as escalation when there are particularly risky situations, and the first set of prescriptions being reviewed by a clinician. But a step towards autonomous prescription medication renewal, with the idea that this would be studied and then contemplated whether or not there should be updates to the regulatory regime based on this. And a second example is FDA's Tempo pilot, which is really focused on easing some of the regulation on the FDA sphere when it comes to access to chronic disease technologies. I'll end here, which is just a very light touch onto the social technical landscape. And I think there was a lot of discussion already on this today, and it is vitally important, I think, to having healthcare AI deployment be a success. First, validation is only the first step, and success really depends on how these tools are implemented in complex workflows, which differ across institutions and across different types of institutions. Second, as I think Hugo showed with his demonstration today, there is a lot happening on the consumer front. As patients, patient trust is very important for adoption. Patients who come to see their doctors, they want to know, are AI tools being used and what is the impact on me? But patients are also consumers. Consumers who are patients of healthcare and consumers who are actually using these tools in their everyday lives. And that is absolutely, I think, going to impact what they expect out of their healthcare system. So to Hugo and JP's point, they were going to be bringing in their findings from interacting with these chatbots to their clinicians, and they will be much more detailed than they were before. I think they're going to be expecting easy-to-use interfaces, and that will be important. And this was something that came out in our discussion in our small group earlier this afternoon, but there may be a time when patients actually demand that AI tools are being used in their care decisions. And then my final question that I'll leave this group with is, the design choices as these tools are being built always embed values. And so whose values are these? To give just an example of one person doing good work in this area, Isaac Kahani from Harvard has a human values project where he notes that the same tool in the hands of a provider will yield a different result than when that tool is in the hands of a payer. Those kinds of decisions and ensuring that these tools are built with patients at the center is going to require active, intentional views by everyone who is working on them. Thank you. I look forward to the discussion.
Great. I will pick up that thread on the consumer space and what's going on there. Maya asked me to speak in general terms, sort of about what's going on, and that could take 5 or 6 hours. But fortunately, we spent a little while with Hugo earlier delving into this topic, and I'll just pick a few things to talk about that I think might be interesting in this context and for this discussion. So, we're now in a world where health AI for individuals it's here, right? It's been coming. It's maybe works, maybe it doesn't, but it's here. Right, so all of the major AI model builders are now releasing tools, or their tools are being used and co-opted for the purpose of personal health AI. We even have Epic will soon be rolling out services that are focused on the patient, so patients will be able to have a chat-like interface with their health records coming from a particular health system. Every application in the consumer health space that you can imagine either has or will soon be providing AI insights and AI chat based around your health and your sort of pseudo-health data. And of course, this is, as someone pointed out earlier in one of the panels, this is meeting a demand, right? This isn't just because companies feel like this is cool. I mean, maybe some do, but for the most part, this is meeting real built-up demand. We're at a point in time in the US and, more broadly, where our care is increasingly having to be, provided by ourselves, right? More of our health is placed in our hands than ever before, but we also have very limited sets of tools with which to do that. And these AI tools are starting to fill that gap. And it's a massive change for the paradigm of how this stuff has worked in the past. And so this is, of course, super promising, right? We saw everyone raising their hand earlier. The polls that I have seen and the studies that I've seen say that something like 33% of adults have used AI at one point to ask for advice about their medical records. Those same polls say that half of those people have at one point uploaded their own medical records into these systems to ask for help. Right? So this is happening. And for every positive story that you see, for every interaction like we had earlier with Hugo and his dad's data that seems positive and maybe is leading to good places, we're reading stories and we're hearing stories about the possible negative impacts of all of this and how it comes about. There's this thing that we keep hearing about, the pace of innovation, right? In healthcare, we're sort of an industry that moves in decade-long cycles, right? The time from the first discovery of a drug till the time that it's mainstream is, eons compared to the pace at which these models are changing and the pace at which we're adopting these technologies. But something that I also heard, interestingly, a couple of weeks ago at a conference, that several panelists were talking about this concept, this very concept, and one of them made a comment that was, we tend to sit in our very nice institutions where we have access to very good healthcare. We're talking on a daily basis with providers who are the very best at what they're doing. And we tend to think about comparing these AI models and the use of these AI tools to that paradigm, right? But when, in fact, what we should be doing is comparing the use of these models and their efficiency and their accuracy and all of this to the care that people are actually receiving, which might be not seeing a doctor at all. It might be seeing only a primary care provider once every few years in a rural community, right? So there's a lot going on here to unpack that I think is a lot more complicated than just, are these tools good or are they bad? Are they working or are they not? And so finally, my last little plug about some things that we're doing and some things that I think that folks could work on that would be helpful to get conversation going. So, I work on a very, very narrow little slice of this. I'm not making models better and saving the world. But, we do work on this project called Jupiter Health, where we're aggregating data from people's different data sources, whether that be clinical or wearables, right? And we would like to provide people with the tools with which to make sense of that using the various AI models. And so, we're taking steps like providing MCP servers, model context protocol servers, that help guide patients through interactions, help models be guided through interactions with these data in ways that are hopefully more informative, based on clinically derived algorithms rather than sort of hearsay, and hopefully that makes some difference. On the consumer health side of things, our Common Health application lets you bring records in from all across the ecosystem, and now we have some privacy-preserving tools that let you share those with models of your choice to gain insights. And for the rest of the room, who are maybe designers who are going to be thinking about how we interact with these tools for years to come, who are technologists who bear some of the responsibility not just for making them better, but for building in some of the necessary protections and guardrails to keep them running smoothly, to academics and policymakers who, I'm just going to quickly encourage not to kind of succumb to the ease of, well, the big public companies are making these models and they're so great, what can we do? So that's my plug and hopefully slightly engaging comments.
Fantastic. Well, thanks for the fantastic lightning talk. So to kick it off, I'm going to dive right back into a controversy that we left simmering on the last panel, but I would really feel like has been simmering all day, so it makes it maybe a good panel conversation. So on the one hand, we have the potential for vast democratization, consumers taking care of their healthcare records, improving access to all sorts of data, and perspectives. We heard from Zach, who said, the libertarian perspective. We heard from Hugo, who said, I'm not afraid, I want to dive in. And then the other, we're seeing like real risks, right? So real risks to trust, to privacy, to essentially consumers or healthcare systems being preyed on, and that I think we heard some of that from Bob as well. So now on our panel, we're exploring the societal deployment environment. Where do each of you stand? What are we doing? Because I think we heard a beautiful description of that landscape. What should we be doing? And I'll pass to Cora first.
Okay, so I think we need to be action-oriented. I think we need some baseline rules, and I think we need to have a healthy dose of, humility is what I would say. I think we need to be adaptable. So I think there do need to be, I don't think we can throw up our hands and say, no rules whatsoever, because that's not the land we want to land in. And I think there are definite risks. At the same time, I think they need to be take into account the fact that the landscape is moving so quickly. This is one of the reasons why I like the idea of a regulatory sandbox. This was something that UC Health actually supported. Those kinds of creative thinking, even in the regulatory sphere, I think are very helpful. So I'll stop there.
Oh, this is such a tough one. So for me, in the spectrum of like techno-optimism versus, the world is going to end because of the AI models, I think I at various times occupy either end of the spectrum, depending on, which is the latest thing that I've read or which latest piece of tech that I've seen. But the key for me is that like we're at this juncture right now where we're at the point where it's time to start building the world that we want to live in, right? And it's the people in this room and in rooms like these around the country and the world that are going to be building that world. And there's a lot of choices that we can make, right? Whether it's as regulators or designers or technologists, as I said. But some of the things that I think we tend not to think about in these circumstances are the sort of more long-term ramifications about the choices for which models we use for which things. We heard that earlier. Some of the choices about we need to move quickly and we need to ship this code. We need to get this implemented in our health system so we don't fall behind the other health systems. 2, 3, 5 years from now, what sort of situations have that left us in? So I agree with the action-oriented comment completely, and think that we need to find ways to take actions that fit into broader and more longer-term perspectives, as opposed to the kind of like move fast and break things. We heard a little while ago about the velocity of the software development going on in Silicon Valley these days, and I sort of challenge. Does anyone outside of Silicon Valley think that the velocity of software development by Silicon Valley developers increasing is a good thing? Well, you don't have to answer.
Yeah, I'll just pick up a few threads from what JP and Cora said that I think really resonated for me as someone who is in charge of designing health policy and regulations, certainly in the healthcare space for Medicaid. One is that this technology is here, and I think whose values are we prioritizing and what are the problems that we are trying to solve will determine what that future looks like, right? If you just let the market go, you will get a lot of solutions for largely affluent consumer bases who are going to purchase that product. That is not going to solve any of the deep access issues we have in healthcare for a third of Californians. That is not going to solve the deep mortality and morbidity disparities that we have by socioeconomic status, by income, right? And so the solutions you get to are very different depending on who's designing those solutions and what problems we're trying to solve. And I do think there's clearly a need for better utilization of AI in the public sector. We have workforce challenges that could be alleviated with better use of AI. We have decision making, to what JP was saying. You can't compare healthcare to like the world-class healthcare you get at UCSF, right? We need to compare it to what is the average experience of an average Californian, in my role. independent of do you live in a rural county in the rural north where maybe you have a primary care provider who's a fresh NP grad with 2 years of training and hasn't seen your condition versus you're getting access at UCSF. And there's a lot of use cases for how you can improve clinical decision making, standardization, evidence-based medicine with the use of AI and better population health management models. And then it's, how do you actually design technology that can integrate with where different systems are starting from? I think the sort of Byzantine nature of healthcare, where every system is a different setup, is real. And, at the state, I'll say, our chief data officer says this all the time, half of our systems are COBOL mainframes that literally cannot interface with any modern technology whatsoever. And yet that is the backbone for healthcare for 14 million Californians.
Yeah, just one quick thing. The comment about the systems that we design for affluent people are not the same that are going to solve problems for 30% of Californians and beyond. That's so important because this isn't just a health equity question. So many of the challenges and the goals, right, that we hear societally about AI and these technologies is like solving the healthcare problem in America. Well, we just heard what the healthcare problem in America is, and it's not going to be solved by tech that's only designed for the affluent. So it's just a great point.
Yeah, and I do think, just to piggyback off of that, there's such this idea that you can just lift and shift, right? That's where you design, then you drop it in a public hospital or an FQHC, and magically it works. And prior to my state policy, where I spent a decade working in, the healthcare delivery side, running FQHCs in public hospitals, and I can tell you, none of those commercial solutions really solved our day-to-day problems in those systems.
Do you have follow-up, or you're getting ready to everything above. I'll end it there.
Fantastic. So maybe let's pick up that equity thread, because I think that was a really strong theme for each of you. And we've heard it throughout the day. So we've heard a little bit about the potential of these technologies to upskill patients, democratize access, sort of upskill providers, and including not just MDs. And then I think we've heard less about it, but I'd love to hear a little bit from you, Palav, about roles in maybe upskilling counties or different levels of the healthcare delivery system. So yeah, maybe talk a little bit about how in your perfect world with the right policy, we could see these things play out for improved equity.
Yeah, so obviously, I think the safeguards are critical. We know our people on Medi-Cal and otherwise are using, going to ChatGPT, asking it questions. We know about the host hallucinations. And so I think however this technology is deployed, making sure that first we are doing no harm is going to be critical. And at least with our risk predictive algorithm, we very intentionally, what the outputs drive is who's getting sort of special outreach or extra engagement efforts to get connected to services. We are not using it for benefit determination to say, oh, if you don't fall into this risk tier, you're not eligible for that program or that service, because we don't think the guardrails are, safe enough right now to use it to deny people services. I think similarly, there's concerns about prior authorizations. If you automate everything and someone who truly needs that service is denied, that can be catastrophic for that individual, right? But here it's lower risk, because it's really, hey, these people probably are higher risk, they're gonna have a bad event, have someone or an automated solution outreach and see if we can get them plugged into care and get the services. The worst case scenario is they don't get outreach, and today they're not getting outreach anyway, right? So compared to our real world scenario, there's only upside risk here, not downside risk. I think thinking through, the opportunities of how this gets scaled are endless. So at the county level, we have all these programs, right? County behavioral health, we are in a behavioral health crisis. The expectations of what individuals have to do to screen members, get them connected to therapy. There's just so much human labor going into all sorts of things that can and should be automated. We also know that the people who show up to the front door for any services, whether it's in county behavioral health or to our hospitals or managed care plans, are not the ones who are most at risk and sitting at home, maybe having a stroke or heart attack and don't know that they have a primary care provider, don't have access. And so I think thinking about how can we empower systems in the SafeNet to truly do population health so that they're not just focused on people who show up at the front door, which is essentially how safety net medicine operates today, but can really identify those at highest risk, which is what our model is trying to do, is huge untapped potential.
No, I guess the one thing I'll add is that, and this isn't a knock against big corporations, although you will probably hear me make those at various times, but, the goal of the big corporation is generally not to service this community, right? And that's fine, that's not the purpose. And that means that the models that get distributed to the individuals in these communities generally are going to need to pass through organizations that take care of those communities. And then it starts to become an issue of cost, of compute, of all of these kinds of things. And most of the high-end models that we're running today are simply too costly to use for those specific use cases. So, there's opportunity, which is, in my way of thinking, that means that there's opportunity to actually be able to do work, really good work, in developing the models that are less expensive to run, that require less compute, that are better fit for purpose and not quite as generalist, so that we can actually deploy them in the places where we most need them in a way that's effective and sustainable.
And one thing that I'll just add is, I think part of the inherent tension, at least in the safety net, right, is the way we finance our entire healthcare system. So most models really are, you make money by saving money and making profit. You do not make money by achieving population health outcomes. And that is an inherent tension for every, entity, whether they are for-profit, nonprofit, Medicaid, commercial, that until we can figure out the underlying financing to say we want to pay for actual patient outcomes and pay for patient experience, that tension's always going to be there.
Yeah, and I would add incentives are very important. So I think, with the large models developing so quickly, finding a way to incentivize that kind of collaborative efforts with counties to actually achieve some of these goals is another avenue that I think could potentially be explored, so that there is not such unevenness in the marketplace.
Great. So I think I'm going to take a minute now, actually, and open it up to audience questions. If not, we'll come back up here for some questions. But any questions from the audience? Oh, everyone's fading. Oh, we got one in the back. All right.
Hi, I'm Jean. Thanks for your talks. My question is, given how rapidly everything is evolving, what, from your perspectives, are the most important policies that governments need to be implementing or institutions need to be implementing? How should we be thinking about those things?
I'm happy to kick us off. So I would say, and this is my personal viewpoints, not representing the viewpoints of the administration. One is just sort of what is your internal decision-making and prioritization process, right? I think how fast the technology has moved, it has forced our department to weigh, what is our governance process? And we had gaps in that, right? It is not that we've had this amazing governance process to dictate how we use technology, what are acceptable uses, what are not acceptable uses that have kept up with sort of how rapidly things are moving. And that is, at the end of the day, what is going to help us mitigate harm in the short term. I think in the long term, it's a lot of what you have been hearing, right? How do we, ensure what does liability look like when things don't get right, because that is often how things will get litigated in the courts and help prevent sort of really egregious behavior. What are the values and true north that we are driving towards, so at least the way technology is being deployed in Medicaid, we can sort of put in guardrails about what it's being used for, how it's being used, and making sure that it's not just being used to deny services or maximize profits at the expense of, healthcare outcomes.
So I'll add on to that. I think that there should be baseline privacy and security regulations that are consistent across sectors and context specific as well. What I think that will do is it will alleviate a lot of the concern that individuals have about what is happening with their data, whether that those data are being held by large companies or being held by government entities. I think there is a lot of concern due to the lack of transparency, I would say, about data flows. And so I think some baseline rules around that that are very clear would be helpful.
Agree.
Yeah, as not a policy expert, but as someone who has developed lots of consumer applications in this space within the context of a lot of the policy, one thing I can say is that there currently is a large dichotomy between the regulation and policies in the healthcare domain and then in the consumer domain. But today the lines between consumer and health are so blurred that the crossover is where most of the good stuff is happening. And so the one plug that I would have would be that for any new policy and regulation that does come out in this space, that it is a little bit more uniformly applied across industries so that we don't end up in that same sort of mess again.
Okay, so I have a follow-up question from that. Should there be one standard, or, I mean, we've heard a lot, like Hugo's saying, you know what, actually I don't care about privacy as much as I care about other things. And I wonder as well, the current younger generations certainly have a different premium on privacy than at least my generation did, and that maybe that will continue to evolve. Should we be aiming for kind of that uniformity, or do people think that the priority of privacy is going to shift? And maybe also just bring in another quote that really struck me from Hugo earlier. Patients adopt at the speed of desperation. Doctors adopt at the speed of trust. We're historically in healthcare, very risk averse, do no harm. And yet we heard from Bob this morning that healthcare systems are collapsing. So are we going to be moving into an era where healthcare systems are adopting at the speed of desperation? And if we're not adopting at the speed of desperation, are we actually doing harm by acting too slowly? So that's a whole mouthful. Reflect.
Well, I'll say, I guess, a couple of thoughts. One, I think there is an argument, and when I was living a previous life in DC, I thought that it could make sense to get rid of HIPAA and only have one single sort of set of rules. I am now part of a provider group, and I don't think that is going to happen. I think HIPAA is with us to stay. I think we have to develop a set of rules that acknowledge that and build, and they can still be very consistent. I think JP's larger point is that there is right now a regulatory patchwork. There are a lot of different federal agencies that sort of have a stake in the game, and then there are all of the state laws, and that whole universe together really creates drag on the system. So whatever that can be done to streamline that, and it doesn't mean sort of giving up on rules, is a place that I think would be very positive to move towards. I think that, to JP's point, the unevenness that exists in the current world where people are getting information from ChatGPT and then bringing it to their provider is confusing, and it's confusing not only for patients, but also actually for companies operating in the space, I think, who then have different incentives to develop products in certain ways depending on which kind of regulatory box they land in. This also happens, I feel like, with FDA regulation as well. And so again, I think that moving to a more even, streamlined world, which is by no means an easy task, is something that is worth achieving. I think the privacy point is a very, very good point. I think even the studies that were done years ago about people's actual preferences versus their revealed preferences when it comes to privacy is very telling. I think there was an MIT study where students agreed to a lot of giving up of their personal information for a slice of pizza, for example. It was cheese pizza is what that researcher told me at the time, because she gets that question a lot. And so I think that you're going to see a lot of difference here, but what is very important is, I think, to recognize that it is context specific. So there are definitely situations where people very much, and they should be as free to do this as they can, share their information to achieve the results that they want. But what I also think we want at the same time is to recognize that people generally do not want their data shared in ways where they do not expect that there will be a negative outcome to them, or in ways they reasonably would not expect. I think one of the challenges is very hard to take that general principle and put it into a set of regulations that work.
Yeah, no notes on the first part. That was perfect. On the privacy, I think we're pretty much on the same page. So Helen Nissenbaum, someone I work with, has written about contextual integrity, right? And it's very much this idea. Privacy is not necessarily about the letters of the law. It's about people's expectations in different settings and making sure that those aren't violated and that they're supported, right? And it is difficult to regulate, but I mean, one of the ways I think that we can start to move in that direction is just making sure that when people have expectations about the privacy setting that they're in, that they're upheld and met, right? That terms of service don't change every 3 weeks with complete, upheaval of what can happen to your data and what cannot, right? That when people don't believe that their data are being leaked elsewhere for other purposes, that in fact they are not. Maybe it isn't necessarily about rewriting privacy law, it's about rewriting the enforcement and the way that it's presented to the population.
Totally agree, and +1 to all of the things that you said. And I think in addition to sort of the privacy and security, we need to really start looking at what is the opportunity cost of moving too slowly. And so this has been coming up, for the last 5 years. We've been doing a lot of work on behavioral health and physical health integration. And obviously with the substance use disorder 42 CFR protections, it comes up over and over again, right? Where those laws were written at a time totally appropriate. There was much more stigma around substance use disorder and accessing treatment. But at that time, when those laws were written, Google didn't exist, social media didn't exist. Like literally, you can find out more about people and their substance use history by looking at their social media accounts or Googling them. And then meanwhile, providers and doctors who are trying to take care of patients cannot access critical information about people that is firewalled in many of our SUD systems. And I think it's just a great example of how our regulations just don't keep up with changing societal attitudes about privacy and security and don't always meet that intent either of, is this rational? Did you read this, 10-page legalese document every time you download an app and consent to something and really understand what you're consenting to?
Great, so I think we are actually at time. Unless there's a burning question from the audience, I think we can thank our panelists. All right, thank you all very much.